Welcome to PEM Currents, the Pediatric Emergency Medicine Podcast. As always, I'm your host, Brad Sobolewski, and today we are talking about Psychogenic Nonepileptic Seizures, or PNES. Now, this is a diagnosis that often creates a lot of uncertainty in the emergency department. These episodes can be very scary for families and caregivers and schools, and if we mishandle the diagnosis, it can lead to unnecessary testing, medication exposure, ICU admissions, and long-term harm. This episode is going to focus on how to recognize PNES in pediatric patients, how we make the diagnosis, what the evidence says about management and outcomes, and how what we do and what we say in the emergency department directly affects patients, families, and prognosis. Psychogenic nonepileptic seizures are paroxysmal events that resemble epileptic seizures but occur without epileptiform EEG activity. They're now best understood as a subtype of functional neurological symptom disorders, specifically functional or dissociative seizures. Historically, these events were commonly referred to as pseudo-seizures, and that term still comes up frequently in the ED in documentation and sometimes from families themselves. The problem is that pseudo implies false, fake, or voluntary, and that implication is incorrect and harmful. These episodes are real, involuntary, and distressing, even though they're not epileptic. Preferred terminology includes psychogenic nonepileptic seizures, or PNES, functional seizures, or dissociative seizures. And PNES is not a diagnosis of exclusion, and it does not require identification of psychological trauma or psychiatric disease. The diagnosis is based on positive clinical features, ideally supported by video EEG, and the management begins with clear, compassionate communication. The overall incidence of PNES shows a clear increase over time, particularly from the late 1990s through the mid-2010s. This probably reflects improved recognition and access to diagnostic services, though a true increase in occurrence can't be included. Comorbidity with epilepsy is really common and clinically important. 14 to 46%, that's a wide range, of pediatric patients with PNES also have epilepsy, which frequently complicates diagnoses and contributes to diagnostic delay. Teenagers account for the highest proportion of patients with PNES, especially 15 to 19-year-olds. Surprisingly, kids under 6 are about 1/4 of all cases. So it's not just teenagers. We often make the diagnosis of PNES in epilepsy monitoring units. So among children undergoing video EEG, about 15 to 19% may ultimately be diagnosed with PNES. And paroxysmal non-epileptic events in tertiary epilepsy monitoring units account for about 15% of all monitored patients. Okay, but what is PNES? Well, it's best understood as a disorder of abnormal brain network functioning. It's not structural disease. The core mechanisms at play include altered attention and expectation, impaired integration of motor control and awareness, and dissociation during events. So the patients are not necessarily aware that this is happening. Psychological and psychosocial features are common but not required for diagnosis and may be less prevalent in pediatric populations as compared with adults. So PNES is a brain-based disorder. It's not conscious behavior, it's not malingering, and it's not under voluntary control. Children and adolescents with PNES have much higher rates of psychiatric comorbidities and psychosocial stressors compared to both healthy controls and children with epilepsy alone. Psychiatric disorders are present in about 40% of pediatric PNES patients, both before and after the diagnosis. Anxiety is seen in 58%, depression in 31%, and ADHD in 35%. Compared to kids with epilepsy, the risk of psychiatric disorders in PNES is double. Compared to healthy controls, it's 8 times higher. And there's a distinct somatopsychiatric profile that strongly predicts diagnosis of PNES. This includes multiple medical complaints, psychiatric symptoms, high anxiety sensitivity and levels, and solitary emotional coping. This profile, if you've got all 4 of them, carries an odds ratio of 15 for PNES. Comorbid epilepsy occurs in 14 to 23% of pediatric PNES cases, and it's associated with intellectual disability and prolonged diagnostic delay. And finally, across all demographic strata, anxiety is the most consistent predictor of PNES. Making the diagnosis is really hard. It really depends on a careful history and detailed analysis of the events. There's no single feature that helps us make the diagnosis. So some of the features of the spells or events that have high specificity for PNES include a long duration, so typically greater than 3 minutes, fluctuating or asynchronous limb movements, pelvic thrusting or side-to-side head movements, ictal eye closure, often with resisted eyelid opening, ictal crying or vocalization, recall of ictal events, and rare association with injury. Younger children often present with unresponsiveness. Adolescents more commonly demonstrate prominent motor symptoms. In pediatric cohorts, we most frequently see rhythmic motor activity in about 27%, and complex motor movements and dialeptic events in approximately 18% each. Features that argue against PNES include sustained cyanosis with hypoxia, true lateral tongue biting, stereotyped events that are identical each time, clear postictal confusion or lethargy, and obviously EEG changes during the events themselves. Now, there's some additional historical and contextual clues that can help us make the diagnosis as well. If the events occur in the presence of others, if they occur during stressful situations, if there's psychosocial stressors or trauma history, a lack of response to anti-epileptic drugs, or the absence of post-ictal confusion, this may suggest PNES. Lower socioeconomic status, Medicaid insurance, homelessness, and substance use are also associated with PNES risk. While some of these features increase suspicion, again, video EEG remains the diagnostic gold standard, and we do not have video EEG in the ED. During that monitoring, typical events are ideally captured, and epileptiform activity is not seen on the EEG monitor recording. And video EEG is not feasible for every single diagnosis. You can make a probable PNES diagnosis with a very accurate clinical history, a vivid description of the signs and look of the events, and interictal reassuring EEG findings. Normal labs and normal imaging do not make the diagnosis. Psychiatric comorbidities are not required. The diagnosis, again, rests on positive clinical features. If the patient can't be put on video EEG in a monitoring unit, if they have an EEG in between events and it's normal, that can be supportive as well. So what if you have a patient with PNES in the emergency department? Step 1, stabilize. Airway, breathing, circulation. Take care of the patient in front of you and keep them safe. Use seizure pads and precautions and keep them from falling off of the bed or accidentally injuring themselves, a family member, or another team member. Avoid reflexively escalating if you are witnessing a PNES event in front of you. If they're protecting their airway, oxygenating, and they're hemodynamically stable, avoid repeated benzodiazepines. Avoid intubating them unless clearly indicated. And avoid reflexively loading them with anti-seizure medicines such as levetiracetam or valproic acid. Take a focus history. You got to find out if they have a prior epilepsy diagnosis. Have they had EEGs before? What triggered today's event? Do they have a psychiatric history? Does the patient have school stressors or family conflict? And then is there any recent illness or injury? Only order labs and imaging when clinically indicated. EEG is not widely available in the emergency department. We definitely shouldn't say things like, this isn't a real seizure, or use outmoded terms like pseudo-seizure. Don't say, it's all psychological, and please do not imply that the patient is faking. If you see a patient and you think it's PNES, well, you're smart. You're probably right, but don't promise diagnostic certainty at first presentation. remember, a sizable proportion of these patients actually do have epilepsy, and referring them to neurology and getting definitive testing can really make that diagnosis a certainty. Communication errors, especially early on, worsen outcomes. One of the most difficult things is actually explaining what's going on to families and caregivers. So here's a suggestion. You could say something like, what your child is experiencing looks like a seizure, but it's not caused by abnormal electrical activity in the brain. Instead, it's what we call a functional seizure, where the brain temporarily loses control of movement and awareness. These episodes are real and involuntary. The good news is that this condition is treatable, especially when we address it early. The core treatment of PNES is CBT-based psychotherapy, so cognitive behavioral therapy-based therapy. That's the standard of care. Typical treatment involves 12 to 14 sessions focused on identifying triggers, modifying maladaptive cognitions, and building coping strategies. Almost 2/3 of patients achieve full remission with treatment. About a quarter achieve partial remission. Combined improvement rates reach up to 90% at 12 months. Additional issues that some of our neurologists and psychologists and psychiatrists face are safe tapering of anti-seizure medications when epilepsy has been excluded, treatment of comorbid anxiety or depression, coordinating all of this between neurologists and mental health professionals, and providing education for schools on event management. Because schools see these events, call pre-hospital professionals who want to keep the patient safe. They often give benzos and expose the patient to additional risks. So this requires a lot of health systems and outpatient collaboration. Overall, early diagnosis and treatment of PNES is critical. Connection to counseling within 1 month of diagnosis is the strongest predictor of remission. PNES duration longer than 12 months before treatment significantly reduces the chance that they'll get the patient into remission. And video EEG confirmation alone doesn't predict positive outcomes, so not every patient needs to be admitted to a video EEG unit. Quality of communication and the speed of treatment, especially more intensive cognitive behavioral therapy, matters the most. So overall, the prognosis for most patients with PNES is actually really favorable. There's sustained reductions in events, along with the mental health comorbidities, quality of life and psychosocial functioning improve, and patients use healthcare services less frequently, which is good news for all of us. So here are some take-home points about psychogenic nonepileptic seizures, or PNES. Pseudo-seizure or other terms are outdated and misleading. Do not use them. PNES are real involuntary brain-based events. Diagnosis relies on positive features. So what do the events look like and when do they happen? Not normal lab tests or CT scans. Early recognition and diagnosis and rapid referral to cognitive behavioral therapy changes patients' lives. So if we suspect PNES, get neurology and mental health professionals involved ASAP. All right, that's all I've got for this episode. I hope you found it educational. Seeing these events in person many times over the years, I recognize how scary they can be for families, schools, and our pre-hospital colleagues. It's up to us to think in advance how we're going to talk to patients and families and develop strategies to help children who are suffering from PNES events. If you've got feedback about this episode, send it my way. Likewise, like, rate, and review, as my teenagers would say, and share this episode with a colleague if you think that it would be beneficial as well. For PEM Currents, the Pediatric Emergency Medicine Podcast, this has been Brad Sobolewski. See you next time.